Hi, I'm Chitra Nabat with General Catalyst. I lead our health assurance and innovation initiatives. I'm pleased to be the moderator of today's session. Rajiv, would you like to introduce yourself?
Yeah, hi Chitra. Pleasure being here. I'm Rajiv Rananki. I'm president of Anthem's digital platform business.
Marcus?
Hi, I'm Marcus Osborne. I lead the health innovation function for the Walmart Health and Wellness business.
Rajiv, Marcus, thank you so much for joining us and for participating in today's session. Shall we dive into our conversation?
Let's do it.
Let's do it.
So we're seeing a continued shift of procedures from hospitals to physician offices and clinics. How do you think this impacts how patients receive care and how systems administer and get reimbursed appropriately? Rajiv?
Yeah, Chitra, great question. I think we're seeing lots of different shifts on kind of where care gets delivered, how it gets delivered by whom, and so the way that we think about it is ultimately let's kind of put this together with the consumer at the center of this, rather than them being the afterthought. The patient-centered experiences, consumer-centered experiences driving how this all needs to get laid out. And the way that we think about it is there's digital care options, there's virtual care options, including virtual primary care, chronic condition management. And then there's obviously always going to be a need for in-person care delivered at the appropriate setting, whether it's clinic or it's a physician's office, home increasingly, and of course the traditional hospital settings. But in all of that, just kind of let's create a common thread of how the user experience ought to get better and how the data needs to be more interoperable and more integrated, and that the consumers have transparent and easy to choose options that let them kind of pick the right venue for their care and the one that's most convenient and most appropriate for the type of condition that we're treating. And from a reimbursement standpoint, I think that is going to obviously change the dynamics. And what we're doing at Anthem is to continue to sort of increase our footprint of value-based care arrangements. And more, whether it's primary care physicians or it's systems or other partners, bring them together into an outcomes-based, value-based care incentive arrangements, so that where care gets delivered ultimately is decided between the patient and their physician, and we're providing the technology, the infrastructure, and the experience necessary to pull it all together in a way that makes sense for them.
Rajiv, can you give us an example or some more specifics? Because a lot of folks talk about, the user experience, more personal, value-based care. A lot of these buzzwords, not to say that you're using buzzwords, but these phrases, so can we double click and bring it to life a little bit more with an example and some more specifics?
Sure. So we recently launched a new function, Chitra, called virtual primary care. And that's available on our digital assets, like our mobile app for our members called Sydney. And, so any user that is an Anthem member that uses our digital asset can essentially sort of have a virtual care appointment on schedule, or it could be an urgent care visit, 24/7. Now, so let's say you start there. You have your virtual primary care visit, and let's say you also have your existing primary care relationship, as well as you have the associated network that's tied into your product. So from that virtual care visit, now you can traverse into and say, now, I've got a condition that requires a lab. Perhaps I need to go and see a specialist if it's something that requires an in-person visit. Now, our virtual primary care physician can direct that, so they can provide the appropriate options on which labs to go to that are most appropriate for what they're trying to get done, and also kind of surface the specialist based on outcomes, quality, cost, as well as Anthem's recommendations on what works best within the benefit plan of that particular member, and surface that to the virtual primary care physician. So then with all that information at their fingertips, then they're able to say, here's your next best action that you ought to take, and then direct our member to the appropriate physician in our network. Once the in-person visit is scheduled and done and taken care of, then we transfer that data from that visit back into the virtual primary care physician's EMR, so that there's any follow-up questions, any follow-up rehab that needs to happen or therapy that needs to happen, then that virtual primary care physician can take it from there and make sure that we deliver care in a continuous and an ongoing manner.
Marcus, your perspective?
Yeah, I think going back to your original question, I think I see sort of two kind of realities that I think are driving that movement. I think one is exactly as Rajiv mentioned, that fundamentally, if our goal is to help people get access to the care they need and do it in a more affordable way, more accessible, convenient way, in a way that's simpler for them, I think increasingly this kind of movement to other channels of care is the sort of path forward. But I would say that what we actually see happening is sort of now the kind of next step in that, which is it's not just kind of movement into some of these, whether you call them kind of alternative channels for care, but actually seeing many of the kind of organizing of those channels into an omni-channel experience. So the idea of being, in sort of our world, this idea of helping people get the care they need now, get the medical care they need now, the behavioral health support that they need now, the dental care or vision care or hearing care, the care they need now. But where that's not about just physical sites of care that might be at retail. It's not about, leveraging telehealth. It's not about leveraging digital health solutions and AI-driven solutions. It's not about care in the home. It's not about care in the community. It's actually where all of those channels, where increasingly they're integrating and creating experiences for consumers that no one channel by itself could have delivered. And often and increasingly doing it with in a technology-enabled way that allows you to have new types of professionals playing roles in terms of that delivery of care that don't rely on you using and or aren't reliant on providers and professionals that are in low supply. And so I think about what we've seen certainly during COVID. Not just the kind of greater engagement with teleclinical services, but where often those services were being delivered not by a primary care physician, but by a nurse practitioner or a PA or others. I think about in Boston, where you see Partners Healthcare launching wildly effective disease management programs that use technology, but in which the individuals who are providing support and care are grad students. And these may be grad students who are getting a doctorate in philosophy. So these aren't even people who are necessarily trained and steeped in healthcare, but are proving to be more effective than the traditional system in terms of providing support for those who have chronic illness. And so I think certainly, we see and frankly are investing against this omni-channel experience that we believe that by delivering it and allowing people to get care today, it actually decreases the likelihood they'll need more expensive, more complex care down the road. I think the other thing is probably important to note on that as well, that this kind of movement into these alternative channels, that one of the things that those alternative channels are engaging in a much more robust way is they are focusing the care they're delivering around evidence-based approaches. They're assessing, they're looking at what does appropriate care look like, what should be the clinical standards for doing only the necessary and appropriate care. What does quality, what does high quality look like? And so increasingly, and they're attacking the variation challenge that we are all facing. And I know certainly on our own associate side, for our own associates on our own health plan, where we're the largest self-insured employer, variation is killing us, right? And when I say killing us, I actually truly mean it's killing us. It's fundamentally harming the health of our associates. It's costing us billions of dollars as an employer in unnecessary and inappropriate care and poor quality care that's driving to poor health for our associates. And so this idea of some of these alternative models being able to use data and analytics and insights to drive to true high-value care that is non-variant in nature is also quite compelling. And I think it's going to then kind of challenge the traditional health systems to say we've got to get there too. We've got to figure out how we think about delivering omni-channel care that may not be about driving people to the hospital. We got to think about how we reduce variation amongst our providers and our practices that fall under our health system umbrella. And so I think in many ways these kind of these newer or less traditional kind of care represent ways to fundamentally transform both the consumer experience and also fundamentally impact the overall quality of care being delivered in the system.
Marcus, you used some very strong terminology there when you talked about how it's, killing us, right? And you're talking about your associates. You talked about new participants, alternative channels of care. Talk about what motivated Walmart in terms of, its call to action to get involved. And then if you can share with us, what Walmart is doing.
Yeah. I mean, the motivation for us is pretty simple. I think often, I would say, I've been with Walmart for, over a decade and a half. And, what I've learned is when people say, they will say, well, we know what Walmart is. Walmart is a discount retailer. And I say, actually, you don't understand the business of Walmart. The way I define Walmart's business is we're not in the retail business. We're in the business of trying to understand what fundamentally consumers need, and then trying to get them the things they need in the most effective way, as affordably as possible, as conveniently as possible. And so when we say save money, our motto is save money, live better. We mean that about life. Like we're trying to help people in the U.S. and globally save money on whatever it is that they need and live a better life. And we're committed to both those causes. And so then back to your kind of question, what does that have to do with healthcare? Well, fundamentally, it doesn't matter what time frame you look at. You can look at over the last 3 years, you can look at 5 years, 10 years, 20 years. It doesn't really matter. If you ask this question, particularly of Americans, what is the number one thing that causes the greatest amount of stress, angst, and concern in people's lives? It's actually not the economy. It's not jobs. There are moments of time that it is, but in aggregate, if you look, it's actually healthcare. It's this sense that the system, the fear that I can't get the care that I need for myself and my family. And so when you look at those challenges and you ask the question, well, what's causing all the stress? It's a belief that the healthcare system is unaffordable. It's a belief that it is intentionally inaccessible and inconvenient, that it is intentionally complex and unserving. If you go back to our purpose is to figure out what consumers need and then figure out how we can serve them and get them what they need. And if they're saying that the biggest thing that causes stress and angst in their life is the healthcare system, whether we like it or not, and if we want to be around in 5 years or 10 years or in 20 years, we better figure out how to play a role in terms of helping them get what they need. And so then to your question, what are some of the things that we've done? I'm sort of mindful. I mean, again, with the launch of about 2 years ago of the Walmart Health Model, which are these integrated centers that have a full array of services, as I mentioned, from full primary care, where the vast majority of visits are actually for people with chronic illness or for preventative or wellness needs. It's where there is mental health services, where there's social health services, where there's access to physical therapy for the vast numbers of people who are dealing with musculoskeletal problems. There's access to dental care and vision care and hearing. There's access to nutrition services and other services, but they're all integrated, and it's accessible to people in the mornings or the evenings, throughout the week and the weekends. It's accessible to people regardless of whether they have insurance or not. So we do take insurance, but we're also clear about cash pricing. And so probably one of the areas that I think people have talked the most about is they say, well, is what you've done, what Walmart has done on the mental health side, where we said, if you have a mental health need and need to engage with a therapist, you should be able to get that. And so we charge people $1 a minute, basically, $60 to sit with a therapist. And in some of the markets we've been in, the cost of those services were double or triple that previously. And so this idea of trying to make care more affordable for the people who need it, going beyond that, we've acquired a company called MeMD, which was a telehealth company, which becomes part of our desire to create this integrated omnichannel experience. And that even more recently, I think we announced a deal with Transcarent, where the intention is how do we enable employers of all sizes to leverage what we're building. So it's, yes, we built it for consumers, but we also think it's good for those who pay for the care of individuals. And so we'll continue to try to and do that with groups who are committed to transparency in the system. And so we will continue to kind of look for opportunities like that to enable us to bring what we're building and the groups that we're partnering with and the solutions that we're helping organize to help them reach more people in the market.
Yeah, Marcus, I love your call out of transparent. That's an important General Catalyst portfolio company, and part of what transparent is about, and both of you talked about this in your remarks, is this notion of working together. And the question to you both is how do you think that evolution unfolds or that evolution looks in terms of actors in the healthcare ecosystem working together? You know, at General Catalyst, a big part of the way we think about our health assurance methodology and thesis is responsible innovation through radical collaboration. Nice words, challenging to accomplish given the fact that as you all know, in the healthcare industry, incentives are not fully aligned, right, between those who receive care, those who pay for care, and those who provide care. And that's a barrier. And so when we think about the next wave, the next phase of how organizations can collaborate, what does that look like? And what do you think the critical steps or ingredients are to unlock that in a material way? Rajiv, yourself.
Yeah, that's a lot to unpack there. And I think that's a great topic and a great question. So I'll answer it from Anton's perspective. You know, how do we go about sort of addressing the different elements of what you just asked, Chitra? So, in some ways we call ourselves the digital platform for health, and we've talked about that for the last 3 or 4 years, and we're positioning that as sort of an evolution of our traditional health insurance business. And that we've done that for the last 70 years, and I think that model's great, but it needs to rapidly evolve into what you just described. So to do that, then we've created this digital platform, which essentially, as any platform would, has kind of 3 fundamental components to it. One is the supply, which is through our provider network and integrating them into our platforms. The demand, which is to consumers via digital voice and contact center and other ways in which we interact with our consumers. And then all underpinned by a data foundation that promotes interoperability, as well as a wealth of algorithms and machine learning and artificial intelligence capability that optimize supply and demand. So then in doing that, we've specifically said we're not going to build everything, nor are we going to own everything. Whereas some strategies of others in the industry call for acquisition of care delivery infrastructure, integrating that and creating a fully closed loop. And it works in some cases, but I think there's an issue of how do you scale that nationally. So our view is that if you were to connect the supply and instrument it and understand the quality and the availability and the price point of that supply, and then match it up to the consumers as they need it, proactively in many cases, and address sort of issues that before they arise and become severe chronic conditions, then I think we have a way in which we can address fundamental cost issues, quality issues, access issues, get it ultimately providing more affordable care to the members that we serve. Then the partnership comes in two ways. One is, let's say a company like Transcarent or a Commure or any of the things that are in your portfolio alone. They all could be, sort of embedded into various sort of components of the platform. So on the supply side, let's say a company like Commure that's working on interoperability, APIs, and enabling providers to connect and developers to build on top of those connections. Why not work with them? And then on the demand side, there's any number of digital therapeutics and care options. Marcus mentioned behavioral health and mental health and therapy. Well, there's cognitive behavioral therapy, there's conversational AI support for therapy. There's machine learning and intelligence that's driving personalized recommendations around that, finding the connections between chronic conditions and behavioral health. all that's being surfaced through a number of sort of digital options. But frequently those options are on a standalone island somewhere that are not connected to the rest of the healthcare system. So our view is that if you're able to seamlessly connect digital, virtual, and physical care options, from a demand perspective, and make it seamless for consumers to interact and access that, and then do the same on the supply side, and then use a common foundation for interoperability, then absolutely radical collaboration is indeed possible. And in some ways, we've proven that already, and we're continuing to scale that.
And Marcus, before we come to you, on that point, Rajiv, and how do you, and I'm sure there's, healthcare system CEOs that are watching and tuning into this forum. How do you think healthcare system CEOs get on board? Because when I talk to them throughout the country, even some in the Midwest, and they talk about, going to the payer, going to Anthem, and it's like, I've got so many constraints. My payers give me so many constraints. It's not going to work. Can't activate these conversations, can't activate a new conversation. They feel this, negative kind of overhang, right? And so what would your advice be to healthcare system CEOs?
I think it's, one, we've made our solutions for our systems agnostic to payers. So we believe that we've designed systems with the physician personas in mind, the clinician personas in mind, and not a system that works for Anthem that kind of needs to plug into some legacy infrastructure that exists, but really built from the ground up with sort of human-centered design kind of principles in mind, with actually solving the problems that our system partners have told us that need to get solved. So those are things like, make things like prior auths easy and automated, and make it seamlessly a part of the workflow. Make claims payments and any questions around that seamless to deal with. Make things like transparency around the program integrity processes that we have in place, so that we both don't have to build up these kind of war chests to fight each other on what's been billed and was it appropriate or not. Let's align the incentives and clear all the barriers out of the way, so that all of the admin inefficiencies that have grown up on both sides of the equation can mutually be removed through more trust and transparency. And then where there are differences on what contractual sort of structures need to be in place, then let's kind of work through those kind of open issues together, as opposed to focusing on all the things that are inefficient that continue to perpetuate because there's kind of one or two issues that get in the way of solving the bigger problem. And I think it's in this mechanism, someone's got to lose, and I think the losers are the ones that are going to be the providers in the systems that aren't sort of delivering to the highest quality, and the ones that are of the highest quality will only get more business and will drive more volume to them, as well as sort of keep the independent primary care physician practices independent and thriving, which is, I think, another sort of related issue to the question that you just asked, Chitra.
Marcus, your perspective on what Rajiv just shared about those who are going to provide the best quality will be the ones that win. Your perspective on that, and then if you can also dip back to the original question I asked.
Well, I'd agree with that. I think probably the one thing I'd add is the one addition on that is the basis for judging that isn't going to be just purely based on quality, but it's going to be on appropriateness. And it's because I use a different definition for both those. And when people kind of ask, often when I think about quality in the system, quality means if you do something, do you do it well? Appropriateness is a more fundamental question. Should you even be doing what you're doing? Is it even necessary? And so I think increasingly those two questions of, are you delivering appropriate necessary care? And when you do deliver the appropriate necessary care, do you deliver it at a high quality? Do you deliver it in the right way? And so, I fundamentally agree. I think that we, depending on what you look at, you look at, just from a spend perspective, $700 billion to $1 trillion of wasted spend tied to poor quality and inappropriate care. I just fundamentally, as a society and as a country, I don't know how we can continue to sustain that that. And so I think Rajiv's right. I believe that what you're seeing is this movement to say those who continue to operate delivering the most appropriate high quality care, what I call the high value care, I think will do very well. And those who don't, don't. And I don't know that that's a necessarily bad thing. I think that's the dynamics of all markets. What I will say, and what gives me hope in this is, and there are a number of instances where you've seen it, is that with visibility, with not just access to data, but analytics and insights that allow me as a provider, as a practice, to know how I'm performing, to know, what is the standard, and how do I perform relative to the standard? How do my peers perform? How are they, if they're performing better than me, why are they better than me? What we've seen is instance after instance. There's a big study that was done at Johns Hopkins that proved this out, that providers and practices change how they practice when they have transparency to how they're performing and to the value they're creating, and how they kind of stack up to others. So I think if we want to lift everyone up, I think it does demand, and this goes back to your original question, I fundamentally believe in the partnership model. I think one of the things that it's going to demand is that everybody is going to have to get a little more comfortable in how we share data to enable deeper levels of analytics, to generate better insights that help us not just engage individuals and help them understand their health better and engage their health more proactively, but also insights to help those who are providing care, the providers and the professionals, to understand how they're performing and to figure out how they can up their game. I think that's where there's a deep need for partnership. But I, at the end of the day, believe that there is no one group who's gonna create the solution that's gonna transform this industry. That I believe that the transformation that will come from a coalition of the willing, and I think it's going to come from certainly traditional players like Anthem and some health systems and others. I think it's going to come from some of the group that, or the bucket that Walmart often gets thrown in, the non-traditionals, right? Some of the retailers like Walmart or Walgreens or Kroger or Costco, but also the technology companies like Amazon and Google and Apple and Microsoft. I think it's going to come from the enabling space for the innovators, but I also think there are other groups. I mean, I think about the role that churches and schools and community leadership can play in terms of reaching people and helping them get access to what they need. I think this coalition has to be a much larger coalition than maybe the healthcare industry has traditionally allowed for. You're starting to see some of those really interesting collaborations and coalitions emerge, often in smaller communities, but to great effect. And so I think the challenge for all of us is, how do we take the learnings from those successes and get them to scale? I think I commented to somebody not too long ago, and I still believe this, that I think we've got all the innovation we need to fundamentally change the system for the good. Our challenge now is to take the innovation and the solutions and the things that have worked, but figure out how to get them to scale to reach everyone instead of just, pockets of the population. And I think that's where this partnership is going to get us there. That's the way we get to scale.
And Marcus, any specific thoughts on that scale piece, right, in terms of how to get to scale, whether it's the barriers and really just, strategies to accelerate getting to scale?
Yeah, I think, part of it is, I can answer it in a number of ways. I think one of the things that I sort of think about is that often when the groups who are trying to create solutions often get sort of pulled into silos. So I think about, you mentioned very early on value-based care and the move to to not just deliver episodic care, but how do we deliver proactive longitudinal care to Americans? What I would say is there's been a lot of great work that has been done that has shown, I think, reasonably good impact in some instances. But let's be sort of blunt. Most of that has been directed thus far to a specific subset of the population, to the often the sickest of the sick, and to the Medicare Advantage population, but often isn't, but we haven't seen solutions that fundamentally scaled for the lower income Medicaid populations that are working in the commercial sector, that work direct to consumer, that allow you to reach people even if they're uninsured. What I will tell you is that same kind of longitudinal proactive support that we're providing to the MA population, that's the same kind of care that everybody wants. And what it demands is for us to, what works for a senior who has got a lot of chronic illnesses and is costing the system a lot may not be the same as for a 38-year-old woman who is pre-diabetic, and isn't costing the system as much. But it doesn't mean that she doesn't need support too, and that we shouldn't find ways through innovation to provide that kind of same sense of proactive support, longitudinal support for the entire population. And so I think that's really what is demanded, is for us to think about how we can, not just kind of focus on siloed groups, but how do we, if we're going to build solutions that is about value, that is longitudinal, that is proactive in nature, how do we bring that to the masses? And so I think that's the challenge that we kind of see in front of us, and instead of just kind of focusing on maybe the low-hanging fruit or some specific segment.
Rajiv, how do you think about that scale aspect, just given the powerhouse that Anthem is in terms of influence, economic vote and voice at the table and reach? How do you think about that?
I mean, to make the change happen, I think, Chitra, we have to introduce the new solutions and integrate them into points of scale. So I think of Anthem as an example of a point of scale. I think Walmart is another great example of a similar sort of a business in a different industry. There's the rest of the Blue system. So if you put all these three companies together, these three sets of companies together, we probably touch nearly all Americans. So that being said, how do you actually systematically introduce the solutions that matter into these scaled points to be able to bring it in an effective manner into the consumers? So in our case, what we're doing is, for our 45 million members, we think of them as being connected into the Anthem digital platform. And as I was saying before, we're curating and integrating the solutions that would be appropriate for them, and then continually sort of mining the data to understand what's going to work, what isn't going to work, and then informing the supply so that they can be better informed on the kind of practices around necessity and all the points that Marcus so nicely made just earlier. So that's one way of doing it. Now the question is, how do I take our scale of investments, we're investing billions of dollars in these kind of capabilities, and make it available, let's say, to a sister Blue plan that may or may not be willing to make those kind of scaled investments. And so we're offering those as managed service offerings to other Blues so that they can buy the outcomes without necessarily having to deal with the technical complexity of pulling it all off, so that it's available to them as an option, so that we can sign on more Blues. And then, if the Blues sign on at scale, then we're talking, 100 million plus, lives as a result of that collaboration alone, and nearly, every provider in the country, just given the Blue relationships with the providers in each of our states. Then I think it's partnerships. It's really Anthem and Walmart have worked together on and off over the years. Marcus and I go back a few years. And I think these types of partnerships become more effective when we're matching up and overlaying our capabilities. Take Walmart's supply chain, for example, and could it be applied more effectively in health? And could our Anthem's expertise and data be made available to someone like Walmart, so we can collaborate more effectively and ultimately get to the same sort of basic principles? What do consumers need, and how do we get it to them at a price point that's accessible and in a way that's very convenient? And so that whole mechanics has been solved for so many industries. I think it's now there for the taking for health, and that's how we think about scaling.
Marcus, and actually you both talked about data. Marcus, you talked about sharing data. How do you both think about this in terms of sharing data, what aspects of data, and the governance and the risk appetite around that, the weariness around that? Marcus?
Yeah, I mean, I think it's certainly a challenge. I think people want to know that their information, not just health information, I think all information about what they're doing is sort of protected. But at the same time, what you also see is people saying, I know there's power in my data, and I would like to see the power of that unleashed and unlocked to help me live a better life. And so, you know, I wish I could sort of describe for you, tell you that I'm, know all, have figured out how to kind of do the governance and all, but I don't know that I have. But what I actually have seen is you think about groups, and I'll sort of use an example of one, Microsoft, a number of years ago, the Microsoft research team, in terms of doing an interesting collaboration that sort of integrates some health data with search data, was able to identify that by looking for small behavioral changes in your search behaviors, that those changes, those micro changes in your behaviors were actually acted as indicators of early onset of cancer. So the idea that small changes in your search behavior or could be small changes in how your shopping behavior at retail, or what you're watching on Netflix and liking on Netflix, or doing in social media, could have an indication about your underlying health reality. I think people want to know, I think increasingly with the advent of technology that is, I think, pulling diagnostics and testing and screening out of the care delivery infrastructure and pulling it closer to the consumer. You think about the Apple Watch and how it's increasingly becoming it's going to be one of the most compelling biometric and health monitoring tools that was ever created. The ability of that information to come together to enable me to be way more informed in the moment, to take better action in a much more customized, personalized way is I think, staggering. And I think if you were to ask me, that is the thing that I look at and say that has the biggest opportunity to fundamentally change the health of America. Because I think the more informed, what we know is the more informed people are, the more they're able to be informed, the more they engage, the more they feel in control, the more in control they have, the more you actually see health improve. And so, so I think figuring out the kind of data component and how people can partner and do the analytics and generate the insights is critical, because I think it is what stands to transform everything about our health and about our system.
Rajiv?
Yeah, so maybe just add to a couple of points to what Marcus said. I agree with everything he said, which is I think we need to pivot the axis to where the data has always been owned by businesses in healthcare. So it's been a B2B interoperability problem. Whereas ultimately, if you start with the premise that all of the data that we're creating about our members, our consumers, our patients, whichever synonym you want to use there, it ultimately belongs to them. And you start with a system that allows them to have complete control over the data and transparency on whom they want to share that data with, and construct sort of a new model in which this becomes sort of the predominant norm by which we sort of think about data. I think a lot of the associated governance falls into place and won't get in the way. And we've started to do that already. We're starting to see some success. There's some tailwinds with technologies like blockchain, which enable us to do that more effectively. So I think that's something that we're on our way to solving, and I'm optimistic that we can do so in a relatively short period of time.
Rajiv, Marcus, thank you so much for your insights and your time in our session today. Thank you.
Thank you.
Thank you.